It is my pleasure to welcome back Dr. Michael Liebman. Michael completed his undergraduate studies in gorgeous Ithaca at Cornell University, go Big Red. He then went on to medical school at the University of Maryland, completed urology residency training at Mount Sinai, and as many of us know, came back west to complete his urologic oncology fellowship here in the Department of Urology. He is now associate professor of urology at the Yale School of Medicine, and in the interim completed a Master's of Health Sciences. Amidst all that, he's managed to inspire many medical students and mentor them, two of whom we have in our program today, and I think we like them. Dr. Liebman's research focuses on leveraging large data sets and genomic profiling to refine the diagnosis, treatment, and survivorship care of prostate cancer. So please join me in welcoming him as he gives a talk on data to decisions, how precision diagnostics are shaping prostate cancer care.
Thank you so much. Thank you so much for that kind introduction. I just want to say really what an honor and exciting privilege it is to be back. I see many familiar faces and new faces in the crowd, and I just want to thank Dr. Breyer for his tremendous hospitality, Dr. Carroll last night for a wonderful journal club. And this is a thrill because I was sitting in the seat. I was a fellow here 10 years ago. Time goes by very quickly, and I'm really excited to see how this story has developed. But this is really truly a UCSF story that I'm going to tell about the people involved, about the questions we asked, and so let's dive into it. Okay. So I have some disclosures that are relevant. Veracyte, this is a non-compensated disclosure, but they make the Decipher profile, which I am going to talk about, and Blue Earth makes a PSMA product. So this is a happy homecoming for me. I started my urology training in New York, then had 2 very special years here, which I think shaped the way I do things, the way I think about things, and I've been at Yale for 10 years. And I really have lasting memories. Only 2 pictures survived from my time here. One with Dr. Bain, and I still remember like hustling over to Parnassus. I think that was the story, in your minivan, I believe. Yeah, pretty sure that's your minivan. And equally special, probably more special, is the way that Dr. Carroll and the whole UCSF family welcomed me and my family. My son is now 10, but this is a special day we had in Sonoma. It feels like yesterday. And you know, when you leave an institution, you sort of think that's the end of it, but I'm really happy that the story continues. The music never stopped. We've continued working together. This is a rare shot of Dr. Carroll and his Yale medicine swag. Now I have a UCSF varsity jacket that I'm really proud of, and I spent some time with Matt in Poland, and we've continued to collaborate together. There's a new generation of trainees. We have people from the East Coast who've come west, and hopefully we're going to get some of your best and brightest over to us, but no one wants to leave, so we're still working on that. And I can't do this without talking about what I've learned here, and just maybe going backwards, start with a word of gratitude rather than put it at the end, sort of put that front and center. So, I've reflected a lot about what I've learned here, what I'm continuing to learn, and just to distill it down into 2 parts. Number 1, what should I do with my life? I think that was a big question when I left here. I really didn't know what I would do. And I think the other question is the process, like how should I do things? But to focus it down to 2 things, what I was inspired with my time here is that I should focus on important problems. And I think when you're a trainee, you kind of worry, like, am I going to run out of problems? Like, is someone else going to work on this problem that I'm working on? And are they close to me? Is that project close to mine? But there's no shortage of important problems. We're never going to solve all of them. So it's important to work on those and ask difficult questions. In terms of process, how to do it, we can do hard things. It's really good to challenge yourself and step out of your comfort zone. Probably the most important thing is focus on people. It's all about people, our patients, our community, our peers. We have to push them hard, trust them, build systems, have ownership, and also play a long game, because it's like you blink, 10 years goes by, and these stories and the seeds you plant do continue to grow. So, by that background, this is still very clinically inspired and clinically focused talk. And my training and my experience has really been shaped by new technologies. When I was here, this is when prostate MRI was really coming out into the forefront. We were very excited about it. We heard whisperings about molecular imaging. A lot of the foundational work was done here, so that was very inspiring. Oh, is that? So, molecular imaging was coming on the scene, genomics was coming on the scene, and I think we had this sort of collective question of what are we going to do with all of this? How is this going to impact care? So I want to tell a story about 2 scans, just to frame this conversation. The first, these are real patients that I saw. First is a 57-year-old individual with a PSA of 8 who has a biopsy showing high-grade prostate cancer, and his conventional imaging is negative. This is a few years ago. We get a PSMA PET scan, and he has an area of uptake in his left femur, and he initiates appropriate metastatic treatment. Okay, we think that's a win for imaging. This is good. We identified something that we would not have known about, and rather than having surgery, he had appropriately intensified treatment. But I would contrast that with an individual I saw recently who was treated outside, but I saw sort of for some of the sequelae of his treatment, who had grade group 1 disease that maybe should not have been diagnosed in the first place, and for some reason got a PSMA PET scan. There was some equivocal uptake in a lymph node, and this motivated his surgeon to recommend strongly that he have surgery. So he had an extended pelvic lymphadenectomy and a radical prostatectomy. Sure enough, it was all benign. It was a false positive, but he's dealing with the lasting consequences of that. So I think that's an example where imaging was probably not a good call because it led to overtreatment. So I think that tells the tale that there are potential benefits and potential harms with any of these diagnostic interventions that we do. So the outline today, I want to talk about diagnostics along the prostate cancer spectrum, talk about some of our work looking at when and where tests are being used, and really the focus of this is understanding and estimating how diagnostic modalities are changing clinical management, and some of our work looking at longer-term outcomes and cost. So I think it's no surprise to everyone in this room that prostate cancer is a sustained and growing problem. The incidence of prostate cancer is expected to rise in the next 15 and 20 and 25 years. So this is a problem that's not going away. I think precision is being thrown in this direction for good reason because we still continue to need to find who should be treated and how. There's good news here. I think our treatments are working. So recent trends in U.S. age-adjusted mortality continue to show that there is a benefit to early detection, that the trends are moving in a positive direction. And this was interesting data published last year, kind of actually putting a fine point on it, estimating that approximately 1 million lives may have been saved due to prostate cancer screening and early treatment. So our treatments are working. It's not a time to take our foot off the gas, but really to hone in and lean into precision. There's an expanding array of management options in the localized setting to the advanced setting, and that is continuing to change. But I think what's most striking is the heterogeneity in prostate cancer. This is one of the seminal papers from Sanaj Poonen, who was also a fellow here a few years before me, looking at recurrence-free survival by the UCSF Capra score. So we know that even basic clinical characteristics like PSA Gleason score, clinical stage, stratify outcomes pretty well. And so the risk of recurrence varies dramatically based on those factors. But what are those sources of heterogeneity? These are also papers that were published. I remember being so excited in the fellows room and maybe discussing this with Hao, but when this Cell paper came out from the TCGA looking at prostate, this felt like a big advancement in understanding the molecular heterogeneity in prostate cancer. We see this between patients. So if you profile tumors from different patients, of course, we see different genomic subtypes. But strikingly, we also see differences between tumors in the same patients. And there's even intratumoral heterogeneity. So even if you sample different regions of the same tumor, you see differences. So the idea that we're going to be able to pick someone out based on individual groups is probably not true. There's tremendous differences between patients and also accounting for time because there's evolution in these tumors over time. So it's a challenging problem. And to this, we've approached it with the promise of precision oncology. So rather than a one-size-fits-all approach, the idea that if we can find the right mechanism, the right target, and treat appropriately, we can improve survival, avoid unnecessary treatment, reduce toxicity, and do it in a biomarker-driven way. This is a lofty goal, right? But this was the promise, and I have to say, it sounded so easy, right? You're going to find the mechanism, you're going to find the signal and treat, and you're going to have a better outcome. So, I guess we'll come back to this point, but this is the gauntlet that has been raised. So these are very familiar territory to everyone in this room, but there are many biomarkers that are applied to these problems. I think broadly speaking in 3 classes: imaging, blood and urine substrates, and genomic. So rather than focus on all of them, I'll focus on really just 3 that have really interested me. One is prostate MRI. This is, I think, a big part of the story and how we approach patients with prostate cancer. PSMA PET, molecular imaging, and gene expression profiling of prostate cancer tissue. So we know that prostate MRI can detect significant prostate cancers. It does a really good job at identifying higher grade tumors. There are also commercially available tissue-based gene expression tests like the Decipher, Oncotype, and Prolaris tests. These are generally prognostic, not predictive. So they're not telling us a clear direction about how to treat, but maybe stratifying patients with less aggressive disease or more aggressive disease. But largely, the evidence base for this is derived from retrospective studies, many of them from this institution, where patients were treated in prior eras. That tissue is extracted and studied, and the outcome was evaluated in people who were previously treated. But we don't have as much information about individuals who have knowledge of this test and do a different treatment or go on a different road as a function of what these tests show. And lastly, PSMA PET, again, a story that is close to everyone's heart here, improves the detection of both localized disease and distant disease in the newly diagnosed, recurrent, and metastatic setting. So it's worth saying something about how these tests are used in practice and what does it take to become approved across these 3 different classes. And so I've also had an interest in sort of understanding the regulatory science behind what goes into this. And it's interesting, they're different, right? So for a genomic assay, these do have FDA oversight, but what needs to be proven is that these tools reliably measure what they claim to measure, right? So there's not a clinical implication. You don't need to demonstrate that there will be a better outcome, that you'll reduce metastasis or improve life, but you need to prove that you are diagnostically accurate. MRI is a little different, right? Imaging modalities are thought of a little differently. These are largely fall under the basis of professional guidelines and standards, and once you just get them approved by insurance, that's it. Okay, so it's a lot easier to bring a new imaging modality to the market or a new application of an existing imaging modality than it is something like a genomic test. Molecular imaging is distinct in that you're actually putting in a reagent. Okay, it's a radiopharmaceutical, so it is considered a bit differently. So the FDA does regulate and has oversight on these radiotracers to ensure their safety, efficacy, dosimetry, and pharmacologic effects. So they're interested in these things. And the regulatory bar that they've established is that they need to detect and characterize disease and also impact clinical decision making. So it's not enough to say for the FDA to approve these that they found more spots in the body. We need to demonstrate that they're accurately detecting cancer and that they're impacting clinical decision making in some way. And that's the reason why, even though molecular imaging was approved and PSMA agents were approved in Europe for many years, these studies needed to be replicated in the US. And so to this question, we have been interested in understanding how do all of these testing questions fit into the phases of evidence, right? And so this may be sort of a familiar concept to some people here, but when we're working in the laboratory and doing preclinical work, we're trying to discover new targets, move them into the testing sphere, and determine if they're efficacious. And we've been interested in this question of effectiveness, really understanding how well do these interventions perform in broader populations. Outside of the clinical trial setting, how well do these tests work? And can we use this information to refine safety information and clinical guidelines? So that's kind of the meat of where we're interested. And so I've been very fortunate at Yale to find myself into a group that is really interested in this. And so for those of you who haven't heard of this group, sometimes you see papers from them, but I've been really welcomed with open arms by Carrie Gross and Xiaomai Ma, who are two of my mentors, and I'm tremendously grateful to them. And so this is the Yale COPPER Group. COPPER stands for Cancer Outcomes, Public Policy, and Effectiveness Research Center. And so our goals really are to generate and disseminate new information to improve the care and outcomes of patients with cancer. So that's a big mandate. That's something that I think we're hopefully striving towards. There's also a strong methodologic focus, so understanding ways to ask these questions in a deeper way, and a strong training component. So we're very interested in training the next generation of clinician researchers and policymakers. So this has been a really exciting venue and exciting group to answer these questions. And they've welcomed me as a clinician and surgeon, and sort of understanding the importance of this. So one of the first things we'll talk about is how testing is being deployed and used in clinical practice. So these are some of the questions I think that people come up. It even came up last night about how is imaging being used. This is data from a few years ago from Simon Kim, looking at the use of pre-biopsy MRI, showing that it's used really in a fairly small proportion as of a few years ago, contrasting that with the UK, where it's reaching almost 90% or almost 100%. We have been interested in asking these questions in the commercially insured population, in the Medicare population, and there's lots of data resources out there. We talked about some of them last night. We have a relationship with Blue Cross Blue Shield that provides data to us. So this is commercial claims data. They're the biggest single payer in the United States. Over 120 million persons are covered by Blue Cross. Demographically in the US, it's not even. Actually, California is a weak spot for Blue Cross. But most of the Midwest and the East Coast has a strong Blue Cross population. There are multiple plans that are encompassed in Blue Cross, and that data is fed in centrally into a data warehouse that is called Blue Cross Blue Shield Access. So we get lots of information about the services that have been delivered, payments for those, but one of the conspicuous challenges that we don't have cancer information, so we don't know a patient's Gleason score or PSA. We just know that they have prostate cancer based on the diagnosis code. And so this has been a very valuable tool to understand the regionalization of these services. And so this is some work that we did a few years ago, looking at hospital referral region variation in the use of prostate MRI. So there are 306 hospital referral regions in the United States. These are distinct regions that have been assigned based on unique patterns of healthcare. So you can think of them as just sort of distinct healthcare regions. But the variation is tremendous. There are many areas where very, very few patients are getting prostate MRI, and then there are, of course, some hotspots. This is a recent paper from Cheyenne Smani, who is applying to urology. Hopefully he'll hear about matching soon. Maybe some of the people have met him along the interview trail. But did really nice work looking at contemporary trends through 2022, and we have an update from last year showing that uptake of MRI is increasing, but there are gaps between measures of social deprivation index. So these are area level measures of income, housing, employment, transportation. So there's still gaps that are potentially modifiable in who gets imaging before a biopsy. We've also been interested in the question of regional variation in genomic testing. So this was a paper also from a few years ago looking at the regional variation in the use of post-biopsy genomic testing. So again, there are many regions where almost zero people are getting tested, and there are some regions, there's actually one hospital referral region where 50% of people with prostate cancer get a genomic test. So that's a lot. Zero maybe is too little, but there's a lot of range in the middle. And then we began asking the question of, well, what are the characteristics of regions that adopt genomic classifier testing to various degrees? And this is a form of what's called mixture modeling. So we feed in all of the trajectories over time, and it's a machine learning approach to essentially pull out what those different trajectories are and identify similar phenotypes. And so when you take all 306, there really are 5 that shake out. Some where they're rapid adopters, some are slow adopters, and some in the middle. So that kind of explains some of that early adopter phenomenon. And the faster adopter regions are generally higher income, more college educated, mirroring patterns we've seen in other places. And we recently have reported on similar trends in the use of PSMA PET imaging in Blue Cross. This is data through the end of 2024, showing really stark uptake in the use of PSMA PET by 6-month period, almost immediately overtaking non-PSMA tracers like Aximin that were used before, but almost overnight. This is when the national approval of PSMA happened at the end of 2021, and almost overnight, uptake went up. All of the other agents essentially went down. And here, I think, just to put a finer point on it, this is fluciclovine that was used, sort of uptake was increasing, but essentially went away almost overnight when the PSMA agents were approved. And we see that similar challenge of regionalization of PSMA PET imaging. So the related question is, how are these tests affecting clinical practice? Are they changing the outcome? And just sort of a framework to think about it, is, well, what we know what the intended benefit is, right? That if we detect aggressive cancer, we may do the right thing, we may avoid doing a biopsy, we may identify aggressive genetic profiles, but there are potential risks, okay? So if we do a prostate MRI, we think we're going to detect aggressive prostate cancer, but there's also the potential risk that you find some small amounts of high-grade cancer leading to invasive treatment in someone who was never going to live long enough to benefit from that. That can increase cost, increase treatment-related toxicity. Similarly with genomic testing, if we profile people and we find a clinical signal or a biologic signal, it may not always translate into a clinical signal. That's a challenge. And I think the same issue may apply with molecular imaging, where the stage migration question, I think, is very salient, where finding cancers that are present may not lead to the outcome being very different. This is a nice paper from Andrew Vickers from a few years ago, modeling how prostate MRI, kind of as maybe the first exemplar case, might affect overdiagnosis and overtreatment. And so this is modeling evidence from various published studies, but suggesting that per 10,000 individuals, we're going to find about 1,300 or 1,400 more prostate cancers, lead to treatments in about 1,000 individuals, but probably avoid deaths in about 1 in 500 people. Okay, so you have to image a lot of people with MRI to move the needle. Not saying we shouldn't do it, but I think it's trying to put in more concrete terms what that difference might look like. So a lot of information looking at the analytic validation of genomic testing, but only a few studies have actually looked at the clinical impact in a randomized trial. This is one from Peter Gann and Adam Murphy in Chicago that randomized patients with favorable risk prostate cancer to receiving genomic testing with the Oncotype assay versus not. And really interestingly, the net effect of genomic testing was to move patients away from genomic testing, particularly among those with low health literacy. And that sort of makes sense. When you talk to people confronted with these predictions, a 1 or 2% risk of metastasis may sound like a lot to them. Maybe they haven't heard the word metastasis before. So there may be unintended effects. This was an exciting study that came out, the G minor and G major studies are initiatives from Michigan that I think are asking this in a very interesting and important way. The G minor study evaluated the impact of genomic classifiers on adjuvant therapy in prostate cancer. I'm blocking this here. And so these were patients who had radical prostatectomy with adverse features and were randomized to receive the usual care or genomically informed care. And the outcome was use of adjuvant therapy. So interestingly, in the genomic informed care, the receiving a Decipher test, if there was a higher score, that it was associated with a 6-fold almost sevenfold higher odds of receiving adjuvant therapy. There was not a continuous effect, so when you looked at Decipher as a continuous variable, it was not significant, but being in the high-risk group was significantly associated with receiving adjuvant therapy. So I think this is the first direct evidence showing that knowledge and receipt of this information moves the needle on how individuals are receiving care. We've also been interested in some of these questions, asking them in a bit of an oblique way using observational data. So these are studies that we did looking in the SEER Medicare, the Medicare population linked to SEER. This is in the early days of prostate MRI. And this was really one of the first studies we did with the COPPER group, trying to just ask the question, is use of a prostate MRI or receipt of a prostate MRI associated with observation versus treatment for low-risk prostate cancer? And sure enough, we found that there was almost a twofold higher odds of observational management among individuals who had a prostate MRI as compared with those who did not, adjusting for all other factors. It's not a causal implication, but shows that there is at least directionally a signal there. Similar work shown from Alexander Cole in Boston, who did an elegant study with an instrumental variable design looking at the association between receipt of a prostate MRI and surgical margin status, showing a reduction in surgical margins associated with prostate MRI. So beginning to connect those two questions of how is use of these technologies potentially impacting care. But we've really been chasing this question about, okay, what about imaging and genomics and use of observation at the national level? Because there is this challenge of unmeasured confounding, right? Are individuals who get an MRI, are they selected for a given reason? Did we intend to do surveillance and as a function of that ordered an MRI anyway? So this is a bit of an ecological study. So we're looking at large parts of the population. We don't know all of the cancer characteristics, but leveraging this large national data set from Blue Cross, we wanted to understand regional variations. Since there is that very stark difference between regions in use, we asked the question, are areas that adopted MRI and genomic testing more rapidly, did they have increases in observation versus treatment? So again, we're not looking at the individual patient, we're looking at the regional level. And showed that areas that had faster uptake of MRI and genomic testing also had greater increases in observation. So less overtreatment, more observation at the regional level as well. And Vinay is a resident now at Northwestern in PGY1, but did some really nice studies in SEER Medicare, also looking at these associations between testing and treatment, showing that prostate MRI was associated with greater odds of intensified treatment, looking at initiating androgen deprivation therapy with radiation or pelvic lymph node dissection. And genomic testing was not associated with differences in treatment, again, looking at the population level. So this is some data that we're going to show at the AUA, looking at active surveillance in a new linkage. So, so through part of this, we've been interested in the question of, can we get a bit more granular? So we know genomic information, Decipher scores, but can we get information about the clinical characteristics and the events that happen subsequently? This came out a little pixelated, but there is a national data set that was just published that was cultivated by the Decipher group, so the Veracyte group, provided a linkage between all of their test results with SEER. Okay, so this is population level data. So these are among the individuals in SEER who had genomic testing. They link them and publish this. So you can download this. And we found that there was an association between higher Decipher score and less use of observation using this national data. And that's a good segue into, in the interest of time, I'll skip through some of this, about some of our work looking at linkages. And so this is a national linkage that was already published, but working with the company, we had this question about, can we get more information about the patient trajectories after they've been profiled? Again, we know that these tests are prognostic, that they're measuring a biologic signal, but the question is, what happens in the downstream events? And so we undertook this fairly long process to link these two measures, okay? And so I'll kind of walk through a little bit the anatomy of this linkage and how we did it. So it really has two parts to it, okay? So one is the national trove of data from Decipher Grid. So every time you send a test, it goes off to the company. They have all this information that they're storing about the patient, and including what is on the requisition report. So when you put the Gleason score, the PSA, the clinical stage, all that is stored. And there are other data services that aggregate electronic health record data. So it's a bit of a sobering thought, but a lot of the data from health records are either through the insurance company or through the health system are being anonymously aggregated by big data companies. I don't think many of us were aware of that, but they're doing that. And so through this process, we are anonymously linking the two. So finding the subset of people who had Decipher testing and finding the subset who have real-world data claims, so electronic health record information, pharmacy records, and linking the two. It's done in a very secure way so that no one is seeing the other's data. So there's no genomic information that's being sent to the insurance companies or to the EHR companies and vice versa. But we were able to link almost 92,000 patients who had de-identified health record data and genomic data with insurance records, pharmacy claims, as well as full transcriptomic data. And so here's what it looks like. So this is in the full 92,000, almost 93,000 individuals stratified by Gleason score. So we've seen plots like this before. So there is a lot of genomic heterogeneity by Gleason grade group. And we wanted to ask the question of in the real world setting, so these are real patients who were treated with knowledge of their genomic scores, is the test prognostic? And so sure enough, it does stratify when we look at the low, intermediate, and high risk groups. There are differences. Again, these are relatively low probability events. But these are people who were tested in the real world setting, in the real world clinical setting. And a similar statistically significant difference when we're looking at time to metastasis from radical prostatectomy. And so, I think this is beginning to tell the story of how we are moving from the phase of evaluating prognostic tests to understanding how they're used in real-world practice and understanding, I think, some of the next questions, how it is affecting the quality and intensity of care. And it's been fun to work with Matt and others on this question to study the quality of active surveillance. We talked about some of this last night at the Journal Club, and I think there's pretty good representation here. So I might go through some of this a little faster, but this might be a nice way to actually go into some of the rationale behind what these studies were. So the last question is, understanding how molecular imaging has been used in practice. So there has been a proliferation of these tests over time, and more are coming, right? There's a big interest outside of prostate cancer and other cancer types in neuroendocrine and head and neck and thyroid and lots of other ones. So more are coming, and more are probably coming in prostate cancer too. So just as we showed that framework where there are potential benefits and potential harms, I think these certainly apply to PET imaging. There's a risk for overuse, treatment-related side effects, and increased cost. And so one of the studies that we've been doing with this wonderful group of outcomes researchers, radiologists, healthcare economists is really to comprehensively understand and characterize the risks, benefits, and healthcare costs associated with PSMA PET imaging. A component of that is assessing patient experience and health-related quality of life, and ultimately trying to build a decision model to maximize benefit and minimize costs and harm associated with molecular imaging. So these are the objectives. This is what we're actively working on right now. So I'll peek into some of this. We were talking about these Markov models last night a little bit and what those health states are. So this is, I think, maybe a good way to double click on some of those. And so, we started by, the first models are looking at the biochemical recurrence setting, people who had treatment for prostate cancer, either surgery or radiation, and developed a recurrence. And we conceptualized really three pathways that might go down, right? Either you have a PSMA PET right away, Back in the day, you were required to have conventional imaging in most cases before PSMA PET, so we considered that as well as just doing conventional imaging alone. And we assigned people, in this model, in this simulation model, to these sort of unique health states, right? So a patient starts without evidence of radiographic disease. They may move to localized disease. They may move to metastasis. They might have metastasis-directed therapy, MCRPC, and death. And so to inform these models, we did a retrospective study from our group and also from the Mayo Clinic of 583 patients with biochemical recurrence. And I think, it's a notable finding that when you image them, the majority have a positive finding. Only a quarter were negative, but 50% had visible metastatic disease, 11% had node only, and 15% had local recurrence. So when we extrapolate this data and sort of use these to inform the model and inform the treatments that might happen afterward, the first part of this was estimating outcomes. So this is not a cost-effectiveness question, and I think you asked that question, well, why do cost-effectiveness? The first iteration was looking at outcomes, because that's really what matters. Are patients going to live longer? So the first output was sort of giving a finer estimate that if we do PSMA PET imaging, we're expected to detect disease in more than double the patients and initiate systemic therapy twice as often. So that's kind of the first question. So how often are we going to start someone on hormone therapy or systemic therapy who would have not otherwise? And it seems to be about double. And next to the question of simulated life years and quality-adjusted life years. And again, these are these ways of thinking about the length of someone's life as it might be affected by earlier detection and earlier treatment and the quality of their life. And at least in the biochemical recurrence setting, we are estimating that there is an improvement on average of about a year per individual image, which is quite substantial, as a function of better detection. The possibility of salvaging a recurrence drives a lot of this, so people having effective salvage therapy seems to really move the needle, with also a signal towards fewer deaths from prostate cancer per 1,000 individuals. And we talked about some of these subgroup analyses. The biggest impact seems to be in the lowest PSA group because these are folks who can have salvage therapy effectively and might not require systemic therapy. When we do these, there's a lot of assumptions about how well things are going to work. And so probably I think the most striking thing is that we're doing a lot more sensitive imaging and acting on it. But in all the trials of the metastatic agents for prostate cancer, every single one, the definitions employed to be enrolled were based on conventional imaging, right? So we're extrapolating this molecular imaging group and treating based on what we find in molecular imaging. So how much is someone going to benefit? So we went down a very deep rabbit hole of testing these assumptions, right? How much of a benefit to earlier treatment do you have to have in order for PSMA PET imaging or any molecular imaging agent to be beneficial? And it seems like the threshold is about 20%. So a hazard ratio of 0.8 in order to be effective, to offset the risks of toxicity from treatment. And this is sort of how we put the simulation together. This is some of the cost effectiveness data that we showed yesterday, showing that they may not be cost effective because the treatments are very expensive. But the subgroup that it may be cost effective in is the lowest PSA group. This is the value of information analysis that Brandon was talking about. And so there are big gaps in our knowledge. We have to acknowledge that, particularly in how informative these diagnostics are. I think we know how much treatment is going to cost and what the disease is going to look like, but we don't know as much about the time lag and how well we are going to make a difference and how much we're going to bend the hazard ratio for recurrence and progression. The last component of this, we had a nice discussion also about the health utility values. So when we assign a quality of life to an individual, we're using sort of like older data. And so as a component of this study, we are doing longitudinal surveys. So these are the standard assessments that we do, but we're also doing qualitative interviews to speak with patients and understand how imaging has affected their decision making. So I'll stop there. and conclude by saying that diagnostic and prognostic imaging is a medical intervention. So hopefully I've made that point, that we think of these as fairly harmless, but every time we order a test, this is a medical intervention. I think we are definitely tailoring prostate cancer management better with the potential for both benefit and risk. I'm excited to employ this effectiveness framework, which I think is appropriate to asking these questions, and I think we should all be asking sort of the second and third order effects. Okay, what is happening downstream as a consequence of doing testing? We're using decision analytic models and secondary data sources, which I think ask a complementary question. It's not a replacement for clinical trials. We still need to do clinical trials and discovery work, but I think fills out the story more completely. So thank you so much for all of your time and attention. There are so many people I want to thank in this room. This is really, again, a UCSF story. From when I started, I was really met with such open arms by Peter, Max, Seema, Matt, Dr. Shinohara, even Ben. I remember working with you clinically, and it's just so thrilling to see the bright path and the trajectory of the department. So proud to call myself a UCSF grad and wear my jacket with pride. And great to see the next generation. So thank you.